In this section, we're going to dive into some of the genetic characteristics that are taking place. But first, a gross picture, just to whet your appetite. So this is ductal carcinoma of the breast. And what we're focused on is sort of that white region in the center that has this ability to retract down the tissue. So that tissue really should be more circular in nature versus kind of like a triangle or jagged edges. And so on palpation of that tissue, you can see it's about a 4 centimeter wide lesion. That's going to be stony hard, and that's what the individual would feel if they were doing a self-exam. So how do we get there? How do we get to these conditions of cancer? These mutations that take place. Well, the mutations take place at the level of the genome, and there are different types of mutations that can happen. And each one of those types of mutations is going to lead to different characteristics. And so this is a cartoon drawing that the publisher, I think, does a pretty good job with it, because they characterize kind of the big ones. This isn't all of them, but these are the big ones. This is general pathology. So when you move on, if you become an oncologist, you'll look at this and say, okay, well, that was kind of cute. But there's a lot more that you're leaving off, and that's true. Okay, this is really just to get us started. And so there's these little symbols that we walk around this little wheel, and this is supposed to be a cancerous tissue in the middle. And this symbol is for transcription. So it's saying that that little symbol means that we're taking DNA and we're transcribing messenger RNA from it. And so the cell begins to be self-sufficient. It can decide when it wants to replicate. It's just not supposed to do that all by itself. This symbol with this no cross-out symbol is saying that they're no longer sensitive to anti-growth signals. So the body, one of the responses the body makes to the question that was asked earlier is, if they see a lesion or a tissue that's growing a little bit out of control, you can send a signal to say, well, let's slow down growth. Let's use contact inhibition, so they become insensitive to contact inhibition. This symbol right here is symbolizing tissue invasion and metastasis. This one is showing a limitless ability to replicate. That's really our immortalization symbol. And then a blood vessel showing that they can sustain angiogenesis like what we talked about earlier. And cancer has an uncanny ability to grow new blood vessels from existing vasculature. We call that terminology angiogenesis. Angiogenesis is the growth of new blood vessels from pre-existing blood vessels. And then this symbol right here suggesting that they're evading death, evading apoptosis. So they work outside of the realm of normal cell signals and say, okay, it's misbehaving and I'm going to signal it for apoptosis. Like what we learned about earlier this semester, cancer has a mutation that prevents it from doing that. Okay? So we're going to look at each one of these in some capacity throughout the lecture. We've already looked at some of them, but many of these mutations include this list: clonal proliferation, oncogenes, tumor suppressor genes. We already talked about telomerase, angiogenesis we just mentioned, avoiding apoptosis we talked about, and then also we talked about metastasis. So we actually have some of the top list to cover, but we've covered a bulk of this list already. So the first mechanistic slide that I want to talk about is introducing oncogenes. And what are oncogenes? So oncogenes are a family of genes that when it is mutated, or when it is signaled to be compromised or expressed at high levels, then it can very quickly turn a normal cell into a cancer cell or a tumor cell. So an oncogene is a gene that is at high risk. Okay, it has a potential to cause cancer, and the ones that I want to kind of highlight are proto-oncogenes, and these are ones that promote growth. And that should make intuitive sense to you. Is if you have growth genes, or what we call proto-oncogenes, if they become mutated, now all of a sudden you have a tumor mass growing out of control. The mutation itself can stimulate the oncogene to become cancerous, and now that serves as an autocrine signal to tell it to keep doing what it wants to do. It's giving itself positive feedback. It's talking to itself. It's saying, oh, you should actually replicate. I should replicate. Let's replicate. We replicate. You should do it again. Let's do it again. We'll do it again. Right? So it's kind of this weird scenario that the cell is operating with a conversation all by itself. That's autocrine. There are three main ways that these oncogenes can mutate. One is a point mutation. And in a point mutation, you get a single base substitution that replaces a single nucleotide. And what's showing right here is this little purple stripe. And another nucleotide goes into that. It causes growth promotion to take place where it wasn't before. Just a single point mutation can do that. A second strategy that can do this is gene amplification, where you start making extra copies of the gene, and now the gene is in higher abundance, so you get more product coming out of the production or the transcription of that gene. And then the last one is this chromosomal translocation, where typically you're going to move a promoter into the front location before the DNA is actually transcribed. And that translocation of genetic information causes it to be always on. Always on. So very similar to a point mutation, but you're moving a promoter region up front. You're not having a mutation in a single base pair. Okay? So these are the real three main varieties of mutations that can take place in any gene, and the ones that are most susceptible, like growth-promoting genes, are considered oncogenes. All right? So there's going to be a family of genes now that are sort of police type of genes. And I want to introduce those on this slide, and they're known as tumor suppressor genes. So they play a regulatory role, and if a oncogene is mutated and starts behaving inappropriately, then a tumor suppressor gene has the ability to come by and say, wait a second, okay, time out. Let's fix what's going on here, and then I'll let you keep replicating, okay? And there's a whole family of tumor suppressor genes that we're equipped with. And we're only going to talk about two. That's it. I'm going to simplify it tremendously. We're going to talk about two, the first one being P53 and the second one being retinoblastoma. Okay, so what are these again? These are regulatory genes, okay, tumor suppressor genes, regulatory genes that evaluate the integrity of the DNA. If they see something that's problematic, they make it stop and pause. You have the ability to correct. Say, for example, you want to correct that point mutation. You have the ability to remove the promoter region. You have the ability to turn off the amplification signal, but you have to catch it. So the first one that we're going to talk about is one of the most widely described. Okay, it's not the only one. We're only talking about two, but it's one of the most widely described, and it's called P53. And P53, affectionately, I'm looking at my notes here. P53 affectionately is referred to as the guardian of the genome. Okay? So the terminology guardian of the genome means that P53, when you have stress, and typically that stress, that damage, is going to take place from a number of different categories. Very commonly, it's actually hypoxia. Okay? Hypoxia will stimulate P53 upregulation. So when P53 is triggered, it's detecting a stress in the cell, and it's going to respond by immediately pausing the cellular division and the replication of the genetic information. And so this slide is going to walk us through this, okay? So here we've got ionizing radiation, carcinogens or mutagens, and hypoxia is a certain type of mutagen, okay, low oxygen levels. So here's a normal cell, and this normal cell has DNA damage, right? And this pathway that I'm characterizing down the middle is the way it's supposed to happen. DNA damage in this normal cell, P53 is going to bind to the DNA, and you can see here's where hypoxia comes in. Hypoxia is kind of one of these other types of stressors which causes P53 to bind to the DNA, and this turns on two main pathways, P21, which is an inhibitor, as well as GAD45, which is a DNA repair mechanism. And so it stops replication and then it repairs. And if you have successful repair, then you allow it to go on for replication and division. If you don't have successful repair, then you actually stimulate it through apoptosis. Okay? Make sense? And so that's how you get rid of bad DNA. And we do this on a regular basis. We do this on a regular basis. So years ago, we did this study with this company, and they were really interested in sun damage to the skin. And their theory was that P53 would be a great biomarker, to determine if there was more or less sun damage. And so what we ended up doing is we ended up recruiting in Southern California commuters that would be willing to give up a left arm donation, biopsy sample left to left arm, as well as, not the whole arm. Oh, you guys are awesome. Look how loud you run over there. Oh my goodness, just a small 2 millimeter biopsy. Okay? Yes. 2 millimeter biopsy from the left arm. We left the entire left arm attached. Okay? And we wanted to take it off of the left forearm. Why do you think we targeted the left arm? That's the driving arm, right? That's the arm that you're always like this. Because this one you're holding on to your lady or drinking your big gulp. But this is the one that's on the windshield, or on the driver's side windowsill. But we had to take one off the right so we could compare. And sure enough, they were right. And they had a therapeutic, it was a topical therapeutic to try to mitigate sun damage. But we were looking at P53 levels in these tissue biopsies, small little 2 millimeter biopsy samples. All right. So that's the way it's supposed to happen, okay? Now BAX is an apoptotic gene, so BAX actually can come in earlier on if it detects that the transcription-dependent and independent targets are already defunct. And it can just bypass GAD45 and P21 and just stimulate for apoptosis and signal it for programmed cell death. And then you get rid of it. It doesn't propagate. That's how it's supposed to happen. Now, if you look up conveniently, this is a sad face cell. This was a happy face cell. You guys didn't catch that. Well, you get angry down here. So look at the sad face cell. Okay, the sad face cell loses P53 capabilities. Okay. Hopefully, I was off the camera. You guys are like, no. Hopefully, you're on the camera. Okay. So DNA damage, right, happens. P53 is gone. So you have no cell cycle arrest. It doesn't pause G1. This one pauses G1, right? That's the gap phase before mitosis. There's no cell cycle arrest, no G1 arrest on a damaged P53, and then the mutation just continues to propagate. You get these angry little cells. And watch the YouTube and get the face again. Okay. Does that make sense? That's how P53 works. A lot of these tumor suppressor genes work in this fashion. So the second one that I want to talk about is retinoblastoma. Retinoblastoma was actually the first one discovered P53 is just more widespread. But retinoblastoma was the first one that we characterized. And it also enforces gap 1, G1, which is the gap between mitosis and DNA replication, so M and S phases. And you can kind of see that from this slide, that here's the G1, and this is where we're going to pause. So it has a similar activity, but it has a totally different mechanism. Make sense? So it's our second example. But you can see that this process of pausing and checking, it's like proofreading. That's what this is. It's like proofreading your term paper. Okay? And we have two tumor suppressor genes that proofread the DNA, but use two completely different mechanisms. So what that should tell you right off the bat is that whenever you have redundancy in biological systems, things that are backup or the same, you have a couple of things that actually do the same thing, is probably pretty important. And that's why biology utilizes redundant pathways. So this must be very, very important to have integrity in the DNA, which it is. But this is a totally different process, okay? So here you've got two different phases of retinoblastoma. It's either in an underphosphorylated state, which only has two phosphate groups. So retinoblastoma is actually this coat hanger. See this coat hanger that has all these P's attached to it? And see this coat hanger here is shrunk down, it's kind of clasped down. So the upward arrow, doesn't look like an upward arrow. The upward arrow is E2F. And E2F is actually going to sit down, it's a transcription factor, it's going to sit down on the E2F site. But when it sits down on the E2F site bound to retinoblastoma, this actually prevents transcription, and this complex pauses the DNA replication into G1. And the way that you unpause, right, it's like your TiVo, the way you unpause is you add 4 more phosphates, and this thing lifts off of E2F. Retinoblastoma lifts off of E2F. So it's almost like a little cap. Does that make sense? And when you add phosphates, when you hyperphosphorylate it, it actually lifts off, and transcription it runs. So this slide is showing you normal activity of retinoblastoma. Okay? So now I want you to tell me, if you have a mutation in retinoblastoma, what happens? Well, you never get this complex forming, and so it's always off of E2F, and then E2F is always sitting on its binding site as a transcription factor, and you just let replication run. That's the mutation. So you need to write that down somewhere in the margin, that this picture is showing you the normal process of retinoblastoma and how it operates as a tumor suppressor gene. And when there's a mutation, it's stuck in this hyperphosphorylated state. And it never sits down on E2F, it never blocks transcription, because you never get this histone deacetylase and methyltransferase complex joining E2F and the retinoblastoma to block transcription. Okay? So these are two that you're going to be responsible for on the exam. But there's a whole family of more. So others include, just to go down the list for sake of completeness, VHL, APC, CD95, ST5, YPEL3, ST7, ST14. You don't need to write it down because they won't be options on the exam. It's not going to be like A, B, only, of all these like alphabet soup tumor suppressor genes. I'm just asking P53 and retinoblastoma. You guys with me? Okay. So, along this theme of mutations, one of the mutations that takes place is to facilitate metastatic outgrowth. So metastatic outgrowth is pictured on the right side of the slide. You can kind of see, here's a transformed cell. See it? And then here's the tumor. It breaks through the basement membrane. It moves into the vascular highway. And as it moves into the vascular system, it clumps up it extravasates out, and it forms a secondary metastatic site that grows its own vascular supply to keep that tissue alive. It's pretty amazing, okay? So, in order to do this whole laundry list of stuff that we just walked through, this tissue actually has to do a couple of different things. So if I back up a couple of slides right here, nobody even asks, like, what's this 2 hits for cancer? What does that mean? Right? What is that? Is that you like Las Vegas? You're talking about, what are you talking about? You're doing blackjack? Hit me. The language of 2 hits is referring to mutations on that wheel of mutations that we looked at. So what I'm talking about is, if cancer only has a mutation that makes it grow uncontrollably, at some point, it's going to reach a critical size. It won't be able to grow anymore because it won't get nutrition. And it'll just sort of either die off or it'll just stop growing. So if it can grow uncontrollably and has an angiogenic mutation to give it more blood supply, now it can actually keep going. And if it has a mutation that makes collagenases and other matrix metalloproteases, enzymes that digest away the basement membrane, now it's got a whole other tool in its tool belt, and it can actually break through the muscle layer or the basement membrane, and it can move into a highway network like the lymphatic circulation or into the circulatory system of the blood. Okay? Well, it also needs those matrix metalloproteases to leave the vascular supply. It's going to have to make them down here too. It's also going to need some mutations in order to stick to the endothelial wall. So it's going to need a whole toolbox of mutations. And that's what that need 2 hits on two previous slides is. It's trying to refer to the fact that we are really good about repairing mutations with these tumor suppressor genes. But if you get 2 or 3 or 4 of them and you can't keep up with repairing that, then you run into a situation where now you've got a metastatic lesion that's moving throughout the body. It moves to a secondary site, and then it starts growing into that tissue, and it becomes a secondary metastatic lesion. Okay, so if you can pretend that you're the SI, and you can describe this scenario with words, I think you're going to have a pretty good handle on the material. So I want you to practice this while you're trick-or-treating. Okay? Or maybe this weekend, right? The exam's not next week, it's in 2 weeks. But in your own words, I want you to describe the development of a malignant neoplasm. So now we're using all these big words, but now you know what they mean. In your discussion, include the following terms: normal, dysplastic, in situ, and invasive. See if you can describe some of the mutations that would be necessary for this neoplasm to become metastatic. And maybe pick a tissue. Say, you know what? I'm going to say that it starts in the colon, and it actually moves to the liver. Okay? And how is it going to do that? How is it going to get there? It's got to go through some circulatory system, or it has to tunnel through and break through all of this tissue, which it can't do. You hear about this, so-and-so, grandpa went in for surgery, and they opened him up, and they closed him right back, and they said the cancer was everywhere. What does that mean? Well, it was highly metastatic. It had migrated outside of the vascular system, and it was cruising through tissue because it's making tons of enzymes, and it can just digest its way through. Okay. So the second component of our cancer, this is a liver, right? Maybe your example is colon to liver, or maybe it's lung to brain, or maybe it's lung to bone, okay? Maybe it's lung to lymph tissue, the lymphatics, or maybe it's lymphatics to stomach, okay? So you can pick a primary and a secondary, and you have to figure out how you're going to get the cancer to that location. So here's an example of the liver that's studded with metastatic cancer. because the liver is a huge filter organ. So the liver is a very common secondary metastatic site. Because if the lesion gets into the bloodstream, it's going to circulate through the body, and it's likely going to get stuck in the liver because that's a filter organ. Right? So, how these things survive. We talked about angiogenesis. It's the development of new blood vessels from pre-existing blood vessels. And cancer uses this strategy in order to survive. And cancer itself manufactures this vascular endothelial growth factor. So this is this little symbol kind of at the 7 o'clock position. If this is a clock face, 7 o'clock position, that's this little symbol right here. So cancer itself will make vascular endothelial growth factor beyond what it really needs, what's normally present. Because the idea is if the tumor is manufacturing VEGF and angiogenic growth factor, it's going to stimulate chemotaxis of these endothelial cells to come to the tumor, right? And as they come to, they start building a capillary network that feeds it. And so we kind of already did this, spoiler alert, earlier because of the lines of question, which is totally fine. That just means you guys are, we're on the same page. So, cancer prevention today, some of the most sophisticated targeted chemotherapy agents are agents that actually are leveraging understanding from shark cartilage. Okay? Why do you think that is? What did we say earlier is so significant about cartilage? Go for it. It's avascular. Okay? Well, we have cartilage in our bodies. We have avascular tissue like the cornea. Those might be the only two tissues that are relatively avascular. The cornea, because you have to see through it. If you have blood vessels growing through the cornea, you wouldn't be able to see. Okay? And then cartilage itself is not vascularized. It's avascular. So some of our targeted chemotherapy now, these are drugs. I was amazed when we started researching the types of drugs that are available to us. So like the classic drip chemotherapy where they have the little IV bag and they're wandering around, they don't have any hair, and that still does happen. That absolutely does. But that is not usually the first line of defense now. Now we have more sophisticated medications because we know more about cancer and how it behaves. And one of the things that we know based upon basic research is we know if you starve the tumor and you give it an anti-angiogenic therapy, it will only get to a certain size and then it won't grow anymore. So it's pretty cool how this stuff's working. But cancer is really, really smart. And it's funny that we say that because it doesn't have a neural supply. But cancer itself is a great example of evolution. Now it's microevolution, granted, but it's still evidence that things are changing. And they're changing in a very short period of time. We're not talking about thousands or hundreds of thousands of years. We're talking about in the lifetime of the patient. This cancer is changing. In fact, it might even be like in a 2 to 3 year period that the cancer mutates, right? So let's just walk through this little tree because this is kind of crazy how this works. But here's our little normal cell, and then there's a transformation. There's a carcinogen-induced change. There's some mutation that stimulates alteration of the genes and causes nicks in the DNA. It causes something to happen where replication is out of control. Some transformation takes place. Changes its phenotype. It changes from a squamous epithelial cell to a goblet-producing columnar cell. Okay? Any of those are transformations. So now it's a tumor cell. But just because it's a tumor cell, now you know that we're not too worried about that. We're going to watch it. But we're not really worried until it starts becoming more aggressive. And it starts behaving with other types of features that suggest that it's now malignant and it's not benign. But let's watch what happens if we leave it untouched. The tumor cell itself is going to go through variations. It's going to mutate. And so the red variation right here, you can see the red variation means that it's metastatic. So right away, it developed this mutation of being metastatic. This is the end tumor. And you can see, again, spoiler alert, you can see this end tumor has all these different characteristics, not just one. That's another example of you need more than one hit. You need more than one mutation for the tumor to be successful. It sounds weird to say successful, but if you're putting your, if you're looking through the lenses of a tumor that's trying to survive and do what it wants to do, it wants to mutate as much as possible to have more tools in its tool belt to go throughout the body. Okay? So the red one is metastatic. Well, this variation that's slight pink means that it needs fewer growth factors in order to behave in certain ways. Like, it doesn't need as much VEGF, and all of a sudden it's more angiogenic. It doesn't need as much basic fibroblast growth factor before it becomes proliferative. Okay, well, this purple one wasn't beneficial, so it died out. But then this light pink one became this, blue color, which is now invasive, and that led to this sort of light blue from this turquoise blue, and that's non-antigenic. Non-antigenic means it's hiding from the immune system. Now the body has trouble finding it. So over a period of time, what you're left with is you have this solid malignant tumor that has all these characteristics that allow it to actually become very, very aggressive, metastatic, and move to a secondary location.
Isn't it true that sometimes when you add chemotherapy into mix, that there's signs like the nuclear points or nuclear pumps on certain cancer cells that have an affinity for bringing out those the nuclear radicals that actually are causing that damage, and then you kill off all the cells that don't have those, and then those ones they grow again, and so you basically created a more malignant tumor by acting.
Yeah, so you almost, so what the question is in certain types of cancers, with certain chemotherapies, you can run into the unfortunate situation where you actually select for more aggressive behavior. Because if you give a chemotherapy agent and you kill off all the weak ones, all the ones that survive that chemotherapy agent are not out, they're no longer competing with their neighboring cancer cell. And so you almost are selecting for these mutations that are actually resistant to the medications. And that's one of the reasons cancer treatment is so difficult. It's a moving target. And so my really close friend has said that about mom, is it's constantly changing. And so now you have to constantly move with different types of meds. And that's what a lot of patients don't understand and don't appreciate is, if you get strep throat, you go get antibiotics. And you get a Z-Pack for an infection unless you have sort of a sulfur-based allergy, and they got to find something that's a little bit, more customized. But after 7 to 10 days of taking that, you're feeling pretty good. Cancer, it doesn't work that way. You go on a chemotherapy for 2 to 3 months, and you might have killed off all the ones that were weak, and now all of a sudden you've selected for the ones that are stronger, and they've mutated since then. And they are not responsive to that chemotherapy agent that you first tried. So now all the drug manufacturers refer to them as first, second, and third treatment options. So now if you go, kind of research cancer therapy, you're looking at language about these meds that are like first and second and third level medications. So if you tried this and now it's not working, try this. If that's not working, now you try this. And it's like, so we are getting more sophisticated, but it's still a little bit of trial and error. Okay, so this is a phenomenal summary table. And then we're going to go into some statistics, okay, in the last portion. But if you can really walk through the homework assignment that I gave you in this summary table will be great tools for you to see if you're understanding and put it together in the contents of this class, the level for this class, okay? So you're starting up here with a normal cell. Over here on the left are all sorts of different damaging agents. What is it damaging? It's damaging the DNA. That's what cancer does. It damages the DNA, causes a mutation. Well, you get this DNA damage if you cannot repair the DNA because maybe your tumor suppressor genes are non-functional. Maybe the mutation is with one of them. Well, then you start propagating mutations in the genome. You get unregulated cell proliferation. You don't kill the cells with programmed cell death or apoptosis. You go through clonal expansion, which is the picture we just came from. This is clonal expansion or clonal proliferation, resulting of one characteristic, the metastatic, to multiple characteristics. So now you clonally expand. You add in all these additional mutations like angiogenesis, escaping from immunity, maybe more collagenase production, so you can actually break through basement membranes really fast, and the tumor progresses. Okay? So if you can walk through this tree and insert the details, then you've got a really good handle on this section. You're looking pretty good. Okay? All right. In the remaining time, I want to talk a little bit about some of the statistics, incidences and causes, but let's answer this question. So matrix metalloproteases secreted by tumor cells are important for which feature of malignant tumors? A, angiogenesis, B, anaplasia, C, invasiveness, D, apoptosis, or E, differentiation. C, invasiveness. Why? I agree, but why? Matrix metalloproteases, yeah. Perfect. Thus allowing it to be more invasive and go somewhere else. Okay? So that, kind of an example of how I write a test question on that. Okay. Incidence and causes in the remaining time. So this is a figure that's a few years old, but the relative percentages haven't changed. Right? It's 2008, so a few years, like 6 years, or 8 years. So 8 years old, but the relative percentages haven't really changed. So the biggies, the big issues that you see in men versus women are still the same big issues. So in men, prostate cancer is number one. And in women, breast cancer is number one. So those are the two biggies. Now, again, they're not the only ones, obviously. You can see colon and rectal cancer in this graph is talking about it being very similar amongst men and women. And this is actually incidence by site and sex. It does not segregate out for ethnicity. Okay, so colon cancer in certain ethnic groups is much higher in men than it is in women. Okay? So the biggies that I want you to be familiar with: breast for women, prostate for men. And you can kind of appreciate that based upon the media, right? Just what you see on commercials and where the emphasis tends to be as far as awareness. But it's not to say that cancer doesn't happen in other areas of the body and throughout the body. So the types of carcinogens. So carcinogens are the big problem, right? Carcinogenic agents. Well, a mutagen is a carcinogen that causes a mutation in the DNA. And these carcinogens could be things like radiation. They could be chemicals. They could be pollution. A mutagen could be unrelated to an outside agent. It could actually be inflammation. Inflammatory chronic inflammation could actually could be a mutagen for the DNA. Okay, it could cause nicks in the DNA. So the germline versus the adult line. At the level of the germline, if there's a mutation in the germline, then it would be heritable. But these mutations that were happening are in the adult DNA. And so there might be a hereditary component where if breast cancer runs in the women in your family, then you might be more susceptible genetically to inheriting that characteristic. And that's probably something that's within the germline. But if it's happening, let's say colon cancer, you're wrestling with colon cancer, or patients wrestling with colon cancer, there's no history in the family of colon cancer, then it's probably not a heritable trait. It's probably something related to the environment or that particular patient, and that's in the adult line. So things like chronic inflammation, even infection, or environmental factors like radiation or pollution. So we're going to start looking at some of these here in the next couple of slides. This slide over here on the far right is talking about cancer-related inflammation. And so you can see we've got inflammation or infection on the extrinsic pathway, or we've got an oncogene activation on the intrinsic pathway. Both of these pathways converge, and what they do is they start stimulating an inflammatory response where you get all of these different types of cells recruited. Here's the macrophage and the neutrophil that we're most familiar with, but you can see the mast cell makes histamine, right? The eosinophil also makes histamine. And ultimately, this feeds down to an inflammatory event, and that inflammatory event causes all sorts of problems associated with cell proliferation, cell survival, inhibition of adaptive immunity, and nicks in the DNA that can take place. So, chronic inflammation, disease states that can stimulate cancer, things like ulcerative colitis can lead to colon cancer, chronic asthma that's untreated. So this is like not a patient that says, oh, I've been an asthmatic since I was a kid. Chronic untreated asthma, where you're symptomatic all the time. This can actually increase the risk of lung cancer. Any smoldering inflammation that takes place throughout the body. The inflammatory cells secrete cytokines, and those cytokines include things like growth factors, and now you get macrophages to the area, and you have this reactive oxygen species production for the respiratory burst to try to take care of bacterial agents. Well, if the bacterial agents aren't there, and you lyse the macrophage, you get all of these reactive oxygen species making free radicals in the tissue. And those free radicals cause problems with the DNA. So, uncontrolled long-term inflammation or any of these inflammatory diseases could lead to a cancer state in that tissue in the long term. All right, so infections. How do infections do this? Well, the infection, if it's a virus, it can integrate into the host DNA. And some examples here are going to be like hepatitis virus, right? Hep B and C can cause liver cancer. Human papillomavirus, HPV, can lead to cervical cancer. HIV, which we looked at in a couple of units prior, can lead to a Kaposi sarcoma, which is a tumor that shows up in a lot of these HIV patients and usually presents as these cutaneous lesions. So skin lesions without a lot of internal involvement, but these lesions themselves are like a smoldering inflammatory lesion. And then also non-Hodgkin lymphoma. This is a cancer of the lymph tissue and usually associated with connective tissue, and it's often associated with end-stage AIDS patients, the non-Hodgkin lymphoma. And then the picture that's being shown over here is moving from viruses to bacteria. So the H. pylori bacteria is one that, here's what it looks like. It's one that takes residence within the stomach or in the duodenum and the small intestine, and it causes a smoldering infection from this H. pylori bacteria, and this can cause intestinal or stomach bleeding, ulcerations, and this can increase the risk of duodenal cancer or stomach cancer because of that infection. So when you have an infection or you have inflammation, you want to get it treated. You don't want to leave it unattended. If we kind of fill out the list of environmental contributors that can cause inflammation or DNA damage, or both. Ionizing radiation. Okay, ionizing radiation. Ionizing radiation come from all sorts of different sources. Okay, there are some theories about ionizing radiation around power lines, around your cell phones. Right, a lot of that data still remains undetermined. UV radiation, which is obvious from the sun. Things like asbestos or air pollution or electromagnetic fields that might, around power lines that might actually collect some of that air pollution. This is a picture of a macrophage, and these high-intensity white specks, like this one right here and these over here, that's asbestos particles. So asbestos has been very closely linked to an early onset of lung cancer in patients. And then, of course, tobacco. Now, we're going to only touch on tobacco because in the respiratory section we'll talk a little bit more about it, but I want to show an association between tobacco and other agents that we consume. So you can see the relative risk on the y-axis that we're normally used to seeing. And then on the x-axis, you can kind of appreciate alcohol consumption. So, and then in the colorations, sort of on the z-axis, is the amount of cigarettes, classic cigarettes that are being consumed. And so the relative risk goes up. The highest bar is associated with the highest level of risk of cigarettes, but it's also associated with the highest amount of alcohol being consumed. So we have a couple of different toxins, if you will, on this graph that are being portrayed. We've got carcinogenic agents, there are over 30 in cigarettes, that are known to now cause lung cancer. But when you combine daily cigarette carcinogens with the consumption of alcohol, which suppresses the immune system, that's why it does this, is you get a synergistic effect. You get an effect that's bigger than either of them by themselves. Okay? And so now cigarettes are starting to be replaced by these vaping technologies. And we'll talk about that in the respiratory section. So I don't want to spill all the beans today, but the jury is still very much out on the safety of vaping. Okay, in fact, the FDA is saying that it is not a safe alternative. Now, that's obviously a very conservative approach, but we just don't have enough data. Now, you guys are, and I am too young to remember, but there was a point in our history where it would be really rad right now to have like a pipe, and just be able to like have like a pipe and a bow tie, like a cool Euro hat, and then maybe like a blazer with patches on the arm. That would be really fun. Suspenders, baby. But we could smoke indoors, right? And it was considered to be not a health risk. And this was not that long ago. Okay, now all of us know what the risks are associated with smoking. And vaping is not even 10 years old, right? I mean, mainstream, it's not even 5 years. So the carcinogens that are present in cigarette smoke are orders of magnitude larger than in vaping technologies. There's no question about that. But if you're vaping, drinking, and getting too much sun, while underneath the power line, okay, after you scrape the popcorn off your mom's ceiling, asbestos ceiling popcorn, you know what I'm talking about? So it's just, we run into these carcinogens all the time. And the question is how much is too much? How many inputs do we have, and where do we need to be careful about it? Okay? All right. So there's many different cancers. I'm just highlighting lung cancer in this particular slide to kind of talk about, sort of make you think as you leave our lecture hall. Make you think about the way our body deals with cancer. We see these carcinogens all the time on a regular basis. Okay, so which of the following is not a typical characteristic of cancer cells? Not typical. Loss of cellular self-destruct mechanisms, unlimited replication, autocrine stimulation, decreased responsiveness to growth signals. Not typical. Which one? D, very good. Decreased responsiveness, right? They're more responsive. It's a tough question because of the way it's worded. Are you with me? So you really have to think about it. Okay. Any other questions before you guys head out to go trick or treat? All right. Just be safe, okay? Stay away from those clowns, man.